Okay, so it's now 12:04. We still might have some people coming in later, but I want to take the opportunity to start this webinar. My name is Bjorn, and I'm the Chief Medical Officer here at Steady. We're a specialized diabetes clinic serving anyone in California, and we're pure telemedicine, which I think we'll come into that a little later, but we don't require any in-person visits, and we're diabetes specialists. We are super excited to provide this educational webinar in collaboration with the California Association of Nurse Practitioners. I personally developed a very strong relationship to the nursing profession during my training back in Sweden. And I really hope that you'll notice that a person-centered perspective is infused into today's webinar and what we do. Just a few words about us who are presenting today. I myself trained to be an MD at the Karolinska Institute back in Stockholm, Sweden. And after that, I served at the Department of Internal Medicine at a rural hospital in Sweden before moving to San Francisco to start Steady around 2 years ago. The reason for my move was that I'd seen some interesting technological advances in diabetes that enabled my patients to share data about their blood sugar management and lifestyle with me. But I noted that healthcare at large was not able to follow along. I personally didn't feel that I had the proper training in data analysis, but I also didn't have very good tools to interact with patients between visits. And frankly, I didn't have time to look at their data between visits. And that's basically why we started Steady. And I'm hoping to share some of the experiences we've had so far with you today. With me is Dr. Kavin Wu, our lead endocrinologist. He trained at the Keck School of Medicine, and he is specialized in internal medicine, pediatrics, and endocrinology. And you'll meet him a bit later in this webinar. The focus today is continuous glucose monitoring. We are seeing a huge uptick in the interest of this technology from patients and from providers, but we do know that it's a new concept for many of us, and I want to stress that you don't need to understand all the details we're going to touch upon today to get value out of the webinar, even if your intention isn't necessarily to start prescribing CGMs to your patients. We want to give you insight into what your patients are experiencing, and we think that this will help you connect with them. You can see on this slide the more formal learning objectives, and the California Association of Nurse Practitioners will be sending out a survey after the webinar to evaluate if we've achieved them. To make this webinar a little more exciting, you'll be able to communicate with us through 2 different channels. Most importantly, you can ask questions anytime by using the Q&A function in Zoom. To do so, just click on Q&A, type in your question. You can also vote on questions that others have posed, and we'll stop regularly to look at those. In addition, we'll be asking you questions on our slides from time to time. To answer a poll, you're going to need to open a web browser and put in the address. And I would suggest that you use a second device for that web browser, maybe your phone, if you have that available. You can also obviously open a web browser on your computer to do this. And I want to try this out. You put in the web address pollev.com/steadyhealth658, as you can see on this slide. And the first question here is, where is your current practice? And if you put in this web address, you should be able to point out on the map where you're located. And we can see there are people up in the Bay Area, Southern California. Yeah, it seems to be all over California. I'm gonna stay here for a little while to let you try this. Oh, someone is up on the border. Cool, thank you. And we're going to jump immediately into the next question here, which is, Have you ever prescribed a continuous glucose monitor? And we're giving you 3 alternatives: yes, no, or I have used one myself. Yeah, we have some users on here. I can just tell you that I think my competence as a diabetes provider really improved greatly when I tried a continuous glucose monitor. It was a bit of an eye-opening experience to see your own blood sugars vary. So I highly recommend anyone working with diabetes to prescribe a device to yourself and try it out for a week or two. It seems a great majority here does not have experience of prescribing continuous glucose monitors, and that's fine. I think we've tried to adapt the content of this webinar to work for someone who has some experience, but mostly for people who have no experience of continuous glucose monitoring. So next, I want to show you the agenda for today. And I want to start by talking a little bit about diabetes treatment. After that, I'll hand over to Calvin, who will talk about how to get started with CGM in your practice and how to look at the data. And finally, we'll cover a few case stories that illustrate how you can use the CGM to support patients if they want to make changes to their behavior, but also if they want help personalizing their pharmacological treatment. Now, as you may be aware, treatment for type 1 diabetes started in 1921. And do you know why? That's a bit of a rhetorical question, but 1921 was when Banting, Best, and McLeod discovered insulin and started using it in clinical practice shortly thereafter. Treatment at that point was with once or twice daily injections of insulin, and the treatment was mainly guided by detecting if there was glucose in the urine. And as you may know, glucose is excreted into the urine when the blood glucose level goes up to around 180 milligrams per deciliter, and that's also the highest point on the normal range for a healthy person. While people with diabetes obviously can have higher ranges, and that's what's driving their diuresis. Therapy in the early 1900s was life-saving. It was really revolutionary, but the long-term complications of this treatment was dire. What we considered modern diabetes treatment, though, started in 1981, also after a new innovation. And I'm going to stop for a moment to let you think if you may know what happened in 1981. Well, in 1981, this happened. This is the Glucometer 1 marketed by the company Ames. And for the first time, this device made it possible for patients with diabetes to test their blood glucose at home. The device also made it possible for patients to dose insulin more precisely. And it gave birth to a few large studies like the DCCT in type 1 diabetes and the UKPDS in type 2 diabetes. And both these large clinical trials soon showed that there is an almost linear relationship between blood glucose levels and both the micro and macrovascular complications of diabetes. Basically, the closer blood sugars are to normal, the less complications we see. And this is a graph derived from the Diabetes Control and Complications trial. It studied 1,500 people with type 1 diabetes, where one group had traditional NPH insulin only, and the other group, called the intensive treatment group, was receiving basal bolus insulin, what we now consider the golden standard for diabetes treatment. The trial started in 1983, and it was terminated early in 1993 due to the revolutionary findings of a 6-fold increased risk for microvascular complications in the control group. And I also want to point out that this was followed by an observational study looking at the outcome for the participants over time. And even though both groups had similar treatment and similar A1C levels after the study ended, the group that had intensive treatment had better cumulative survival still 20 years after the trial. And this was kind of revolutionary and gave birth to a theory about metabolic memory, which implies that it's imperative to start ambitious diabetes therapy immediately after diagnosis. And with this background, I want to take us to today and a new chapter in diabetes management, which is the era of precision treatment. And just like with the glucometer in the 80s, the revolution starts with another innovation, and that's the continuous glucose monitor. And you can see a woman wearing a CGM on this image. It's an Instagram influencer and a friend of ours at Steady. The CGM is a small device that the patient would wear like this on the back of their arm or on their belly, and it measures blood glucose every 5 minutes. This image shows the Abbott Freestyle Libre, which can be bought out of pocket for around $75 a month and is covered by most insurance plans. Now, from a patient perspective, this device has some pretty big advantages compared to capillary testing. First of all, there's no pain from finger sticks. Second, it's really fast. You check your blood glucose by looking at your phone, and it takes only about 6 seconds on average compared to a finger prick that takes around 3 minutes on average. It also doesn't expose you in a social setting where you would otherwise need to pull out all your gear. And you don't have to carry around a meter, needles, and glucose strips. You just bring your phone. And a recent study back in Sweden showed that people that were put on a CGM went from testing 5 times a day to 17 times a day. And that's a pretty amazing increase in frequency, and it's a big win. But I would say there's really more to CGM technology than just convenience. And let me just jump into those advantages real quick. First of all, you may be aware that one of the scariest things with diabetes is the risk for serious hypoglycemia. And that is sometimes hard to tell from a patient history. They may come reporting diffuse symptoms, and it could be hypoglycemia, but it could also be something else, right? Now, this is a graph showing 4 finger pricks from a patient who tested their blood sugars. And you can see that the graph you see here is on the y-axis is the blood glucose level, and on the x-axis is the time of day from 6 a.m. in the morning to 6 a.m. the next morning. This looks pretty decent. All these finger pricks were in the target range of 70 milligrams per deciliter to 180. But if you look at the CGM graph, you can see this. So this particular patient actually had 3 events of rather serious hypoglycemia during this day. And this is what CGM does. It can uncover hypoglycemia. Another important advantage of CGM is the concept of time in range. It's the central metric of a CGM, and it represents the percentage of time that the patient spends with their blood glucose in the range between 70 and 180 milligrams per deciliter. As you can see from this example, even though this person has slightly elevated fasting glucose, hovering between 90 and 100 a day, 100% of the time is spent in the target range. And this is actually my personal blood glucose levels. Now, this presents an opportunity to evaluate blood glucose control over time, similar to what you would do with A1C. But there are a couple of advantages of time in range, and I'll briefly get into them now, and Kevin might go more into depth later. But first of all, A1C measurements have a rather large inter-individual variability, depending on genetical factors and hemoglobin structure. Second, as you'll see later on in our cases, A1C cannot be used for very frequent treatment changes, since it takes around 3 months to see a change in A1C. And thirdly, A1C doesn't measure variability. And I want to show you another set of graphs to illustrate that point. Now, as you can see on these graphs, these are all patients with an A1C of 7%. And there can be a significant amount of both hyper and hypoglycemia hidden between an A1C of 7%. In the first example to the left, this patient actually is almost 100% in range. And lowering glucose could be a good approach, while the third patient to the right, if you would just generally lower blood glucose, that person would probably end up with a serious hypoglycemia. So illustrating that variability is very central to diabetes treatment. Next up, I want to go through another advantage of CGM, which is predictions. So this is a screen dump I got from a patient on a Dexcom G6 device, which is one of the continuous glucose monitors that we use. This patient currently has a blood glucose of 118 milligrams per deciliter, which sounds pretty good, right? But you can also see two downward red arrows on this image, and this means that the device is looking at the slope of the curve and predicting a serious low within 20 minutes for this patient. So that means it's actually pretty urgent for the patient to have something to eat. In the more expensive systems, which I'll cover later, this can even generate a predictive alarm where the phone will play an alarm sound and alert the patient that a low is about to happen without them having to manually check their blood glucose. And that's a pretty cool feature. There are even a few systems on the market now that has integrations to an insulin pump, and it can automatically adjust the insulin delivery based on the patient's blood sugar. We have around 20 patients on these type of systems, and we've seen almost near normal A1C levels for some of those patients, and that's really incredible. Next, I want to just talk briefly about how a CGM works. And just like a glucometer for blood samples, the basis is an enzyme called glucose oxidase that reduces glucose to hydrogen peroxide. In the CGM, there is a platinum electrode which is covered with this enzyme, and it's inserted subcutaneously. The chemical reaction with glucose generates a voltage. This voltage is measured by the transmitter, which sits on the top of your skin, and the value is then sent to your phone through near field communication or through Bluetooth. That differs between different brands. So this voltage level is then translated into a blood glucose reading using algorithms that are proprietary for each brand of CGM. I want to point out at this point that it's important to understand that the glucose fluctuations subcutaneously, they mirror those in your blood, but there is a 20-minute delay. So the user may need to check a capillary blood sugar if they have symptoms. And this is a table showing you the 3 dominating brands on the market. For anyone with type 2 diabetes and not on insulin treatment, I would advise to focus on the first one, the Abbott Freestyle Libre. As you can see here, it has decent accuracy, it's very convenient, it doesn't have any alarms, but the out-of-pocket cost is as low as $75 a month or even lower with insurance. The other device you might want to be aware of is the Dexcom G6, which has a slightly higher accuracy, it has alarms, and it's really good for patients with type 1 diabetes. The last brand here is Medtronic, and due to the lower convenience factor for that device, it's mainly used for people who are on an integrated Medtronic pump, at least in our practice. And to summarize this first portion about CGM, I want to say that it's a major shift in diabetes management, and I think it's important for you as in primary care to be aware of it. It's a really convenient technology for patients. It can detect variability. It can give biofeedback that can help drive behavior change, and we'll talk a little more about that later. And lastly, it's the basis for a growing number of decision support systems and even automated insulin delivery systems. And after this introduction about CGM and how important data is in modern diabetes treatment, I'll hand over to Calvin, who will talk to you about how to approach the data. Calvin?
View of glucose patterns throughout the day. The analogy I like to draw here is comparing a finger stick glucose reading to CGM as similar to that between a single photo and a movie. With one, you have a single snapshot in time. The latter, you actually see what's going on both before and after. Even so, these systems offer anywhere from 100 to nearly 300 readings a day, which can seem like an overwhelming amount of information to take in and interpret. Fortunately, I'm here to tell you it doesn't have to be that difficult. And so I'd like to walk you through some simple steps that you can use to interpret the reports you'll be getting from your patients. Next. As Bjorn alluded to earlier, CGM allows us to find this unique metric known as time in range, which is simply how much of a certain time period is spent in this quote-unquote safe zone. The standard reference range, as we talked about, is set at 70 to 180. And that makes sense if you think about what the patient is experiencing, right? Below 70, that greater risk for hypoglycemia, which can feel terrible, be dangerous for that matter. And above 180, they're more likely to experience symptoms of hyperglycemia. Remember, this is where your kidneys start to spill the glucose into your urine. International guidelines for what percentage of readings should fall within this range were just set last June, actually. So this is all very fresh and so forth. And they suggest aiming for a time in range of 70%. Meanwhile, complications from high blood glucose really develop over years, but low glucose levels pose an immediate risk. Therefore, the panel actually recommended that the time below 70 milligrams per deciliter should be 4% or less. By the way, that amounts to nearly a full hour in the low range, so that's actually pretty meaningful. Finally, that leaves time above 180, which is ideally should be kept to be less than 25% if possible. Next. And they also go on to provide some more specifics, but those are the main parameters to focus on. So again, it's time in range 70 to 180 of 70% or more. Below 70, you want to keep that to 4% or less. And finally, the rest of that would be time in high. So hopefully that gives you an idea and kind of a metric to compare these readings as we move forward. Well, realistically, though, given its relatively affordable price points, the CGM you're most likely to be prescribing will be the Freestyle Libre. So fortunately, Abbott provides a web portal at libreview.com that allows you, your patients, to share their data with you remotely. So it really is quite easy to do. So in many cases, patients can actually use their smartphone as a receiver to scan. And what that does is it actually uploads real-time data to the cloud that you can then view and analyze on the web portal. You simply have them download and install the LibreLink app shown here on the left, create an account, then share their data with your personal or clinic account as designated by an email address. You'll notice too that your patients can also share their data with a trusted family member or friend too, with the corresponding LibreLink app as well. So both of these options are available within the app itself. Once you actually dive into the interface, by the way, you can actually, what automatically comes up is actually this clinic view of sorts. So you'll be able to see and organize all the patients that you're working with the system. Here, I give you a simplified view of what you'd see. And I'm taking out obviously the PHI, but you can set each of these columns to display things like their name, average blood sugar, time in range, and so forth. And it lets you filter by each of these parameters. So for instance, if you click on the top header row, and display all your patients by percentage time in range or average glucose, you can actually sort your list by that way. So this really works well if you're seeing patients via telemedicine. You can check their data in advance of the visit or during, and also offers you the opportunity to do remote patient monitoring as well. Next slide. So from there, by clicking into an individual patient, you then have the option to view any number of possible reports. So feel free to check this out on your own time and see if it has what you're looking for. But I'm going to recommend you right away to start with by going to the AGP report, which goes at the bottom, which stands for Ambulatory Glucose Profile. The AGP is a standardized report that exists across CGM systems and offers summary statistics, a glucose profile graph, and glucose daily calendar graphs. So here on the right is a zoomed out view of what the AGP report looks like. But let's dive into each of the main components next, and let's talk about how you can put that information to use. Next slide. So at the top left of this report, you can actually see the specific date interval that you're looking at. So by default, this is often set the last 2 weeks, but you can actually specify anything in the last 1 to 4 weeks, 60 days, or 90 days. I might recommend too that you take a peek too at the percentage time CGM is active, the number right below that. This lets you know how much of the time your patient was actually wearing and using their CGM actively, so that you also don't overinterpret if that percentage is very low. Next, on the top, you'll find the time and range graphs. And this corresponds very closely to the graph I showed you earlier of glucose time and range. So you'll see a breakdown of all the individual readings, what percentage fell within the 70 to 180 standard time and range, and how much above and how much below. Next slide. And next slide. So as a review, here are the consensus goals for time and range I mentioned earlier on the left. Comparing the percentage of your patient to these industry standard goals should help you figure out how your patient is doing, similar to how we typically compare someone's A1C to a goal of, say, 6.5 or 7%. What's nice, though, is this gives you a much greater clarity on where the problems lie. Are they not achieving their goal time and range because they're spending too much time in low? Maybe it's because they're spending too much time in high. You can see the interventions for these scenarios can be very different, even for the same A1C. And this is what CGM really allows you to do and see. Next slide. The last statistic I'd focus on the top half of this AGP report is the average glucose and GMI, or glucose management indicator. The GMI is basically the calculated estimated A1C of the patient based on the average blood sugar readings during the specific time period. The suggestion is that if you had a patient get their blood test now, their A1C should be relatively close to this GMI value. Now that relationship can be a little bit more complicated than that, but even so, it helps you interpret their overall glucose control if you're used to thinking about things in A1C terms. FYI, based on clinical data, a time in range of 70% actually corresponds to an A1C of about 7%. And every 10% change in time in range equates to a difference of about 0.5% A1C. So for example, if increasing time in range from 70 to 80% might lower your A1C from 7 to 6.5%. Okay, next slide. So at the bottom then of the AGP report, you'll find the AGP graph. The daily glucose profiles during this period are actually compiled into one 24-hour day and organized by time of day. In dark blue, which is in the center and it's labeled as the median, you'll actually find the medium glucose level, where half of the glucose reading levels are above and below. This is by itself probably the easiest to interpret if you're trying to figure out where average glucose is highest or lowest. For example, you might find that blood glucose is on average here higher after breakfast, and use that to help you focus on how to dose medication around that meal. Meanwhile, the dark blue and light blue shaded areas represent the glucose variability, showing where the 25 to 75th percentile and the 10% to 90th percentile data lie. If you're not familiar with those terms, don't worry about it. Simply put, the wider the area these areas are, the more glucose can fluctuate during that time period, day to day. I want to draw your attention too to where these graphs can cross your target range. In this example, where the area dips below the lower limit of target range is where hypoglycemia is more likely to occur, which is highlighted in purple. Remember that this contributes to time in low, which we're trying to minimize. Put in perspective too, a low blood sugar can often result in snacking to raise blood sugar, but that can overshoot in some cases and cause rebound hyperglycemia, as we say, which takes away from time in range even more. Okay. Next slide. By the way, if you ever find yourself looking at a graph like this, where there appears to be parts of the graph that are missing, that's likely because the patient hasn't been scanning their sensor consistently. Just a little tidbit about the Libre specifically, it actually stores up to 8 hours of information at a time, but it starts to replace the oldest data with the newest data after that. That means if a patient doesn't scan every 8 hours, these gaps in data will appear. So indeed, if you look at the glucose profiles, next slide, looking at the daily glucose profiles at the very bottom and so forth, you can see that's exactly the case. This is a gentleman who's likely forgetting to scan in the evenings, for instance. Okay, next slide. So time may not permit you to do this, but if the patient's in the room and the clock is ticking, but just so you know, you can also go into the daily log option here to see the data laid out day by day. Here you can see on a much more granular level where blood glucose is fluctuating and use that information from specific days to guide treatment decisions. For instance, let's say the patient remember their lunch for on Friday they ate at a new restaurant. Knowing that, you could probably educate them that what they ate there raised their glucose here from 176 to 300s, and there might be something in that meal that they can modify or avoid. Next slide. Last but not least, LibreView also lets you compare one time period against another, which can be really useful when you're trying to assess the effect of intervention. So for instance, let's say you started a new medication or got a patient to try a new diet 3 months ago. You can then pull up that data from both time segments and compare them side by side to see the difference. And next slide. And that's essentially what this looks like in this case. So yeah, to summarize, a quick glance at these AGP reports can really give you an excellent overview of your patient's glucose control and patterns. In many ways, the goal is to maximize time and range, so I'd start with that as the first thing. Knowing though too that hypoglycemia is dangerous and uncomfortable, and it can also cause rebound highs, as I mentioned, when they overtreat for lows, I'd focus on that next. Then take a peek at the average glucose and GMI. That's a great way to help both you and the patient understand how these glucose averages in the last few without having to get a blood test every single time. And then the next, the trends or AGP graph helps you pinpoint exactly where the highs and lows tend to cluster. Again, think about focusing on lows first because you want to get rid of those. Then look at opportunities to lower the highs. Finally, if there's ever specific information a patient provides about a specific day, you can always open up the daily log to understand what they're describing and how that might help to address their issues. Great. Let's pause there. Were there any other questions to ask?
Yeah, Calvin, there's been a couple of questions that have come in. I think the first question we got was how long do you recommend the use of CGM to patients with type 1 and type 2 diabetes? When and how long do you recommend? Yeah.
Absolutely. So quite frankly, obviously in type 1, there's a lot of value because especially when patients are on bolus and basal insulin, there's a lot of fluctuations and so forth. And you can imagine how this is so much more powerful than just a couple of finger sticks a day and so forth. So generally for type 1, I find it very hard to argue that they should not be on CGM. So oftentimes it unfortunately becomes a cost issue otherwise. For type 2, that's kind of up in the air. I think many endocrinologists like myself do believe there's value even for people who don't require medications otherwise, because you can actually see a lot and learn a lot from seeing your glucose patterns in relation to the meals and activities you do. That said, certainly if you're on medications that can lower your blood sugar, I think that's a good time as well to think about it, because again, you might see that A1C 6.3% looks great, but in actuality, they're having lows and you may need to adjust accordingly.
Okay, and that actually, you got a similar question, which was, do you recommend CGM for patients with borderline A1C levels?
Great question. So I think in terms of the cost, the Libre, again, you can get, and the cost, by the way, that we were quoting at 75 per month, so it's actually 2 sensors. So I truly do think there's a lot of value just putting it on. I'll show you cases shortly where putting on the CGM just changes their world. They know what's going on, and that can actually in the short term make them aware of the things that are happening in their life. And that, by the way, I've definitely had patients where the simple act of putting them on a CGM can lower their A1C dramatically by itself. So in terms of borderline values, I still think there's value there.
Great. And lastly, we had some questions about cost and insurance coverage, and I think maybe we went over that slide a bit quickly before. Maybe you can say something about Medicaid, first of all. Do they cover CGM technology?
Great question. So Medi-Cal, yes. Medicare, yes, but unfortunately for Medicaid at the moment, no. In general, it's pretty difficult. There are certain criteria that must be met in general for Medicare even, but Medicaid, for instance, in general, we've had patients been denied. So a lot of times you're looking at that cost out of pocket, unfortunately.
And what about other like commercial insurance? What's the situation there? Like, what are the criteria to cover a CGM for most of the big commercial payers?
Yeah, so to be clear, the guidelines, a lot of the payers follow Medicare's guidelines, which say that you're on insulin basically, 3, 4 times a day, checking blood sugars and so forth. That said, actually, we're finding more and more that a lot of payers are paying for it, even if they're not meeting those criteria. So, for instance, I've had even people with pre-diabetes who have gone in and their insurance covers it. Paid $30 out of pocket instead of even the 75, for instance. So it behooves you to try. You can send a prescription, have the patient check and pick it up and so forth. And there's also discount codes, by the way, that you can use that get it to at least that $75 price in that case.
Got it. So there are questions coming in. I think I'll just switch to a slide that shows us the agenda for today before taking any more questions. We've covered, I think, modern diabetes care, the basis of this whole thing. We've talked about CGM and how to interpret the data. The next part of this presentation is going to be, around some case discussions. So I think let me just look at the questions and see if there's anything that we need to cover now, and otherwise maybe we'll just defer it to the end of the thing. I think one thing that is that we've gotten a few questions around is how does this actually work? Where do you apply the CGM? Where do you wear it? What do you think, Kevin? Is it a good time to talk about how to do this in practice?
Let's show you actually. So if you're interested, let's going to walk Bjorn really quickly through the instructions. So just really hopefully break down those barriers to think that this is really complicated otherwise. So maybe if you open the package and so forth in the meantime, to quickly address the Libre specifically, by the way, is meant to be worn on the back of the arms. So that's specific to the Libre alone. The other two, by the way, can be worn in the abdomen and elsewhere. So that those sites are also available. Okay. Yeah. So meanwhile, so once you open it up, Bjorn, do you want to describe what you?
I'll describe the contents of the box. So the box has a sealed container which has the actual sensor and transmitter in it. Those are built together in the Freestyle Libre. And it has what they call an applicator, and it has cleaning swabs. And I personally have been using this device on the back of my arm, but I'm pretty skinny back here. So for me, it's a little bit irritating to wear it on the back of the arm, and I prefer the side of my belly. So I'm gonna go ahead and apply one on myself so you can see how it works. Do you want to give some brief instructions, Kevin? How would you explain this to a patient, and do you need to do it in person?
Of course, no, you don't. We've walked many patients over video, in fact, how to put this on, and there's nice instructions included. But put simply, there's the applicator and the canister. So you'll twist open the canister, and the applicator will be, you'll lift off the lid of that. You'll basically line up those two lines together and push down to attach the two. So you can see they're opening the lid basically for that. The other piece will be a canister that you twist. Okay. So once you're done there, Bjorn, maybe you can zoom into the camera to show them the line that exists on both of these components.
I'll just lean forward. So there's a line on the applicator and a line on the sensor, and you just align them and press down.
Exactly. You push that down, and now that's basically ready to apply. So from there, you just basically choose your spot. Again, the Libre is intended for a back of arms, but what you basically then do is just do some alcohol wipes to the area. And finally, you just push, essentially. You just push, and what it will do is basically insert the sensor from there.
Yeah, and just to show you, I don't know if you can see this well, but there is a needle in the applicator, but that goes away after the sensor has been applied. So I'll just use this place. I'll use the alcohol swab to clean it. And then I'll see if I can do this so you can see well. So I basically just press down. There's a clicking sound. And as I lift off, there is the sensor. Does that?
That's it.
Do you want to add something, Kevin?
Yeah, simply to say, a lot of people actually are worried that, and then if you look at the needle, by the way, when you're putting it in, it looks really scary. But the truth is, most people actually barely feel anything, and if they do, it's very minimal, I should say.
Yeah. Okay.
So to be clear, there is a short warm-up period, but from there you'll be able to use the device. So it's actually pretty quick.
Cool. We're getting questions here scattered questions. I think some of them are going to be covered in our case discussion. So I suggest we move forward, and then we'll pick up with some more questions later. Please feel free to keep sending the questions, and feel free to upvote if you really like one of the questions and want to make sure that we answer them later. Okay. So now I want to dive into how you can use continuous glucose monitoring for behavior change. And I think this is for us at Steady, this is a great opportunity that this technology provides. And I think a few points need to be made before I start here. First of all, behavior is key to success in all diabetes treatment. So for us, we treat probably 60% with type 1 diabetes and the other 40 with type 2 diabetes or prediabetes. But behavior is equally important for all those. I think it's important to understand that patients who are on insulin in particular make as many as 200 decisions a day related to their blood sugars, which means that if they can have data to make those decisions, that's going to improve their quality of life quite a lot. I think what we've learned is that formulating very clear and actionable goals for patients is crucial, and most patients tell us that they actually want us to keep them accountable for their goals, which I think is interesting. Even if they've been struggling with type 2 diabetes for a long time, they ask us to help keep them accountable. And then lastly, we talked about feedback loops briefly before. I think you'll see in these cases that the speed of iterating with a CGM is much faster than when you're working with A1C, and that facilitates learning and change of behavior in a very unique fashion. And I hope that these cases will show you a little more of the details of how to do that. So I want to start by asking you another question here, and as you let's see if we can get that. It doesn't seem to be. Okay, I'll skip it. Skipping that question, I want to start talking about Wesley. Wesley is a 40-year-old man who reached out to us because he wanted to reduce his risk for complications from type 2 diabetes. And when Calvin met him for the first time, Wesley had a pretty decent level of physical activity with 45 to 60 minutes of exercise 3 times a week. He also had been trying to limit his calorie intake for quite some time. He had been on different diets and struggling for years. But he had kind of lost hope, I think is a way to put it. And he had reverted to check his blood sugars, capillary blood sugars, once a month. So that was kind of his situation. He was struggling, trying, but not making much progress. What concerned us with Wesley is that even though he had an A1C of 8.5, which isn't a catastrophe, we saw that he had several other risk factors for complications. The most important one may have been his family history of several close relatives who had cardiovascular disease and diabetes. He also had, obesity, hypertension, hypercholesterolemia. So several risk factors. And as you may be familiar with already, each of these risk factors doesn't add a factor of one. They actually, they're multiplying the risk several times. So if you can just get rid of one risk factor, that reduces the risk quite substantially. Wesley had a PCP who had worked very actively to help him lower his blood sugars with medication. And as you can see here, he was on all 3 classes of medication that are firmly proven to have a weight lowering and cardioprotective features. He was on metformin, he was on a GLP-1 receptor agonist, and he was on a SGLT2 inhibitor. And in addition, he was on on a few insulin secretagogues to further lower blood sugars after meals. And the first step for us when working with a new patient is a virtual visit where we go over their medical history. We don't require any in-person visits, and we collaborate with their PCP around any physical exams that are needed. After the first visit, Kevin prescribes a CGM, and in this case, that was an Abbott Freestyle Libre, which Wesley paid for out of pocket. And after the first visit, we ask the patient to wear the CGM for 7 days while taking pictures of their food with our app. And we also allow them to share exercise data and step count from their phone. But before going into that data, I'd like to see if I can get another poll going. Yeah, and this time it works. So if you go back to that website, I would like you to answer the question, how would you go about helping this patient improving their blood sugar control? And as I said, go to a web browser, pull in pollev.com/steadyhealth658, and then you just tap what you think is the best approach here. Yeah, we can see it's dietary changes are still in the lead, but exercise is a close second. Yeah. Okay. And meditation is picking up a little bit at the end here. I personally think that these options are all relevant suggestions. And the way we approach this is we want to look closer at his data before starting the discussion around these treatment changes. And yeah, we'll see where we end up here in the real world. But as I said, all these suggestions are relevant in this case, I think. So the first thing that we looked at, and I think Kevin mentioned this before, is this trend graph that we can find in Abbott in the LibreView web interface. And it shows you a composite of all the blood glucose values for that week of time. Just to repeat, you can see the time of day on the x-axis, and you can see the blood glucose value on the y-axis. The blue center graph is the median blood glucose per time of day. The dark blue shadow shows the 25th to the 75th percentile, and the light blue shadow, the 5th to the 95th percentile. Now, when I'm looking at this graph, I note that the patient generally had high blood glucose values after breakfast and after dinner. We also noted that the blood glucose was generally falling overnight, but there was no sign of hypoglycemia. You can see that the light blue shadow never crosses the 70 line here, which means if he had a hypoglycemia, that was a very rare instance. After looking at this data, I think this is really where a primary care physician should go. And if once you've done this, that's probably enough to start advising the patient. We actually go into even more detail, and I'll show you our system so you get an idea of this. And I think it'll help you see how this person manages blood glucose. So this is a graph from our proprietary system. And it's pretty unique because, yeah, you can see the glucose graph in the middle here, starting at 6 a.m. and covering the next 24 hours. And the reason we start at 6 a.m. is that most people start their day around that time. So it's kind of a behavioral cycle. The light green field on that graph is the normal range. And on top of the glucose graph, you'll see images of food and notes that the patient has logged in our app. And under the graph, you'll see exercise data. And in this case, the patient shared their step count from the phone. So it's automatically collected. The scale on the y-axis for steps is up to 4,000 steps per 30 minutes. And as you can see, this graph actually gives us a bit more color to what we saw on the trend graph. You can see that for breakfast, he had milk and granola, which pushed his blood glucose up more than 200 points. And you can also see that dinner was beans and nacho chips, so a pretty carbohydrate-rich meal, pushing him also over 300 milligrams per deciliter. You won't have access to meal pictures and exercise data on LibreView, but you can still ask patients to log their medication, their insulin doses, and you can ask them to log their meals using text. So you can get pretty close to this depth of information if you can find the time and if you're motivated to get into the details. The reason we get into this detail is because it just gives us so much insight into how this patient is managing their blood glucose. Now, based on this data, we decided to have Wesley schedule time with one of our diabetes educators to go over meal choices. We also decided to replace Bidurion with a more potent GLP-1 receptor agonist, Ozempic. Adding insulin could definitely have been an option, but we held off due to the risk for further weight gain. As you remember, the patient's BMI was 39, so we thought it's worth giving it a shot with diet and some minor medication tweaking. The focus of this educational visit was to help Wesley understand the impact of his different meal choices, but we did not give him any distinct meal plan. And the effect on his blood sugar was pretty interesting. These are bar graphs, and they show his time in range in green and time above 180 in yellow. So the first graph is actually before he started working with us. The second graph is of his first week when he got a CGM and he could see the data for himself. You can see that his blood glucose control picked up a little bit, and we often see this when we put someone on a CGM for the first time. Now, the third graph is after another couple of weeks after that educational visit. And interestingly, just talking to him about his meal choices and showing him the impact took him up to 75% time in range. So seeing the positive result of these dietary changes, we continued working with him over messaging in our app, and also had another 3 more video visits with our team over the next 3 months. And I want to show you what happened to his blood glucose control. So over these 3 months, he made very significant improvements to his glucose control. You've already seen the first 3 bar graphs. What happened was he had 2 more educational visits around diet. The one called Diet 2, we did talk to him about replacing pasta bread and tortilla with root vegetables, because we'd seen that the effect was less dramatic on his blood sugar from root vegetables. And then on the 4th, the one called Diet 3, he decided to increase his fiber intake, but also his protein and fat intake. So he kind of tapered off the carbs a little bit. And then the last tweak here was by Kevin, who saw that he was having a small amount of hypoglycemia. So he stopped using both Novonorm and all the insulin secretagogues. And just to use that trend graph, because I think that's a really good way of understanding his blood glucose control. This is a comparison which you can also see in LibreView. And as you can see, his first 2 weeks with us, at the top here, his average glucose was 177. And you can see the graph where he was hypoglycemic after breakfast and after dinner. Comparing that with 2 weeks, after 3 months of working with us, his average glucose was down to 124. And his time in range was almost 100%. Still, you can see a variability of blood glucose, but it's a much tighter variability. You can see that the light blue shadow is lower around the median than in the top graph. And now I want to hand over to Calvin to talk a little bit more about personalizing the pharmacological treatment. Unless, Calvin, did you have any questions at this point?
We had some questions that were from the holdover from last time. I'm very happy to address some of these questions. Maybe I'll save it to the end though, and I'll be mindful of our time near the
Yeah.
end.
Yeah. So let's we save them. If there are no questions regarding this particular case, then we'll just go ahead and continue, Kevin.
Yeah. Okay, perfect. So these next two cases, I want to kind of show you what you can do using CGM to actually personalize your treatment decisions. Because the truth is, you have a lot in your arsenal, unfortunately, in many of these cases, and it's helpful to understand where the pros and cons of each of these are. And CGM really is your window into understanding which would be the most appropriate. Next slide. So let me share you the story of Oscar. He is a 35-year-old gentleman who was diagnosed with type 2 diabetes at the age of 15, along with hypertension and hyperlipidemia at the same time. He's always struggled with his weight since childhood, then broke his leg recently, which made it impossible for him to resume the exercise schedule he had been keeping to, leading to additional weight gain. This has been a source of stress for him and certainly hasn't helped with his anxiety and depression, for which he was on citalopram and working with a therapist actively. Meanwhile, based on his most recent A1C of 10%, his doctor actually increased the Basaglar, which is his long-acting insulin, which is equivalent to Glargine or Lantus in that sense, another 10 units based on his A1C level. On the right there, you can see the rest of his regimen. So he's on Basaglar, which again is Glargine, a long-acting insulin, 80 units once a day now. He's taking metformin, 1,000 milligrams twice a day. He's taking glyburide as well, the oral sulfonylurea. And he's also taking Ozempic, the injectable GLP-1 agonist. Other things I want to point out, by the way, his A1C most recently was 10 and his BMI is 37.3, so also obese in this case. Next slide. So this Oscar had never worn a CGM before this either. So he had started working with us and after using the CGM for the first time, he was incredibly surprised by how much his glucose levels fluctuated throughout the day and became very motivated to try and control them. So you'll notice that only after the first 2 weeks of working with us, of actually just wearing CGM actually, his GMI or estimate A1C is now down to 7.3% from 10, which is already a vast improvement, obviously, from his most recent A1C. On the right, then, you'll notice that at the baseline, his time in range is now 62%. And fortunately, no nothing in the low range here so far. Next slide. This is the corresponding AGP graph for Oscar's initial 2 weeks of CGM. You'll notice that his blood sugars look like they tend to rise up past midnight and into the morning hours. Meanwhile, there appears to be more variability in his blood sugars around the time of his meals. For instance, if you look in the early afternoon after lunch and also in the evening after dinner. Okay. Next slide. Because we have our meals again, because we have our patients logged their meals and activities for a week, though, I could see that most of his glucose levels were indeed related to his meals. So here are two examples where his blood sugar starts in the low hundreds, but shoots up to 123 and 188 points respectively after the meal, which is definitely adversely affecting his glucose control. Next slide. So, yep, perfect. So meanwhile, then, just so you know, the truth is I had some suspicions that his dose of Basaglar, his basal insulin, might be too high. And that's based on just some calculations of his basal insulin requirements. My theory was that his Basaglar had been gradually increased over time to compensate for the high blood sugars he was seeing after dinner. And this, by the way, this is a common practice that's based on a 2003 study called the Treat the Target trial that popularized increasing basal insulin based on just the fasting morning glucose. But even so, with that concern though, I actually didn't want him to risk having a low overnight. So I purposely told him to fast after breakfast during the day so that he could treat a low blood sugar when it happens. So taking a step back, by the way, what basal insulin should really do is keep blood sugars relatively stable during fasting periods. So what you should see is a nice flat line. So a few hours after meal, blood sugar has stabilized. It really should stay flat, really. With this fasting test, though, again, telling him to fast after breakfast, you can see his blood sugar clearly plummeted from 240 down to 104, which really confirmed my hypothesis that his Basaglar dose was likely too high. Next slide. So let's talk about a concept here. I think it's helpful to take a quick aside and talk about how you can think about glucose patterns and what they consist of. There's a fasting glucose, right? That basically represents the baseline level of glucose when you're not eating. And this largely reflects the glucose that is made by your liver to keep your brain supplied with the glucose it continuously needs. Meanwhile, when you eat something, blood sugar will quickly rise after a meal because you absorb the nutrients from the food you eat. What you then get is this pattern of glucose throughout the day, shown on the right here. Average glucose, by the way, next slide, and hence A1C is largely an average of these two components. For some people, sorry, back one slide actually. For some people, their A1C is high because their fasting glucose are very elevated. For others, their blood sugar shoots up dramatically with meals, and that raises the average. And for some too, it's actually both of these components. So for me, I think it's really helpful to break apart where the problem lies. Is it the fasting glucose that's high? Is it the after meals that are high? Or is it both, right? Because understanding which of these components is really helps you guide your treatment decision. Because something, in other words, is raising your average. Okay, next slide. So let's pose a question. So which of the following would you think would be the most effective choice for reducing his elevated post-meal glucose levels without contributing to weight gain? Okay, perfect. So we have in the lead right now, increasing his dose to Ozempic. We have definitely some votes for Actos, and also increasing his dose of glyburide. Okay, but the majority here will be increasing his dose of Ozempic. Okay, great. Next slide. So here is a chart that nicely summarizes the effects of the various type 2 diabetes medications available on each of these specific components, the fasting glucose, the after meal glucose, and weight. So you can see that each agent here actually varies in its impact on these parameters. So the decision really should be individualized to this patient, right? So in this case, we want something that is most effective for minimizing the rise in blood sugar after meals, okay? And which ideally would also help with weight loss in someone who already has a BMI of 37.3. So you can see here in those choices, insulin is very powerful, we'll say, for post-meal glucose control, but unfortunately leads to weight gain. And this overall makes GLP-1's receptor, the whole class of GLP-1 receptor agonists, a great option for this patient. So given that he's already on Ozempic in that case, it makes sense to increase the dose of that medication to see if that helps. Okay, next slide. So here's a summary, actually, of the medication adjustments I made for Oscar. I reduced his Basaglar dose to 70 units, dropped his glyburide, given his issues with weight and concerns that as I made more adjustments, he might start having lows, and increased his Ozempic to maximize the benefits of post-meal glucose lowering and weight loss. Next slide. And here's the results. Almost exactly a month later, his time in range was 62%, had increased to 88%. And you can see that also correlates well with the average glucose and GMI as well. So the estimated A1C went from 7.3% to 6.5%, all in the course of just 4 weeks. So that's one case, I hope, that illustrates basically choosing your medication based on your needs can be really effective and can help you tackle this issue. Because for instance, increasing his basal dose of insulin here wouldn't have really addressed his after meal spikes, for instance. Basal insulin, given that it's so slow, for instance, is really not intended for the rapid ups and downs that come with meals. So that hopefully illustrates that well. So I have one last case I'd like to share with you, and this is the case of Frank. So he is a 48-year-old gentleman who found us because he had been interested in CGM for a while. He had been checking finger sticks 1 to 2 times a day up until then, but his prior endocrinologist wouldn't prescribe it for him. He had started metformin when he was first diagnosed with type 2 diabetes 5 years ago, but was unable to tolerate it because of GI upset. He then started trying, he was told to try Januvia, but he hasn't seen much improvement with that. So he started on Lantus 2 years ago at 20 units a day, but self-increased it to 50 units over a few weeks based on instructions from his endocrinologist. Meanwhile, he was very intentional with his diet and exercise and went from 380 pounds to 200 pounds over 2 years. So currently at a BMI of 29.4 now. He mentions that he's had hypoglycemia once or twice, once down to as low as 26, by the way. His dogs actually had to wake him up from that. So that was fortunately a good save on his dog's parts. But you can see here, this is a gentleman who has complications, has a very high A1C, has lost a lot of weight in the meantime, and is on Lantus 50 units, Januvia, which is a DPP-4 inhibitor, an oral medication and finally, taking Humalog only to address really high blood sugars. So if his blood sugar spiked above 400, that's the only time he was instructed to give Humalog. Next slide. So, like Oscar, Frank responded really well to CGM. Here in his first 2 weeks of data, where you'll see too that his estimated A1C is now 7.9% compared to his most recent blood test A1C of 11.9%. So, essentially 4% drop just by seeing the data. Meanwhile, on the right, you can see the breakdown of that time and range. So, target range, so in time and range, in other words, was 47% of the time, and the rest of it was in the high range. Next slide. If you take a look at his AGP, you can see that his blood sugar is essentially high across the board, actually. What the other thing to note, though, is there is more variability around the time of his meal. So that's something else to consider. But there's no obvious trends here. And it's fortunate, nothing in the low range. Next slide. So based on his meals and activities he logged during his week-long tracking period with us, Frank also demonstrated a significant rise in blood sugars, as you can see. Here on the left, he had a lobster bisque, which raised his blood sugar 14 points to 242. And he had no idea about the sushi. The sushi he thought would be fine, but it actually rose his blood sugar 128 points into the 350s. Next slide. So a very interesting case now. And what really caught my attention during his initial consultation with me was the fact that he mentioned that his endocrinologist had also checked for antibodies, as they say, and they were mildly positive. Moreover, 180 pounds, even with intensive diet and exercise, seems like a lot to lose in only 2 years. So this raised the possibility to me that he didn't actually have type 2 diabetes at all, but maybe type 1 actually. So to confirm, I sent for a full diabetes autoimmune panel. Go to next slide, which came back positive for the zinc transporter 8 antibody, which raises the possibility of underlying autoimmunity. Meanwhile, I also checked the C-peptide level along with a concurrent glucose. So for a little background, by the way, C-peptide is made by the pancreas in a 1-to-1 ratio with any insulin, since they come from the same big molecule that gets broken down. What's really helpful about C-peptide is basically you can determine how much of the insulin is actually made by the patient, not by the injected insulin. So I want to remind you, whenever you order C-peptide, you have to order glucose value. Because if you think about it, it's important to interpret it in that context. So for instance, if your glucose is low, your body actually is trying to turn off insulin, right? So your C-peptide is going to be low. So it's never helpful there in that situation. So what I wanted to see actually was purposely see a situation where I would stimulate his insulin response if he had one. So, fortunately in his case, his blood sugars were typically in the 180s, 190s and so forth. So when he went for this test, he was 189. And the C-peptide, by the way, came back at 3.9. If you compare that to the reference range on the right, 11.1 to 4.4 was the reference range. And to the untrained eye, this looks quote unquote normal. But I would argue this is inappropriately normal. And the reason I say that is with a glucose in the 189, you would actually expect your C-peptide to be multiple times the reference range. So 3 times, 4 times, for instance. So this was what I call inappropriately normal. And it actually says he's not making enough insulin for the situation, which suggests then at the end of this, functionally, he actually has a delayed form of, he likely has a delayed form of type 1 diabetes. Next slide. So what does this mean? Okay, so there are implications to this actually. One, if he's type 1, he's insulin dependent, right? This is an absolute insulin deficiency. This is where a situation where oral type 2 diabetes medications are less likely to be very effective. So this also means he needs to learn to use basal bolus insulin. So he's got the basal already, but he actually needs to learn how to use his bolus insulin, right? And as an insight to that, and so for those who aren't familiar, when you give bolus insulin, that's a rapid acting insulin meant to kind of cover for meals and for high blood sugars. It's much more appropriate for those situations because when you eat something, your blood sugar rises and comes down really in a couple hours. You want an insulin that acts quickly, that addresses the rise in blood sugar, then turns off because you don't want it to be lingering, let's say 2 days later, for instance, and causing low blood sugar there. So there's a lot of additional calculations you have to be doing. So with type 1 diabetes management, you're often defining what's called a carb ratio. So this is where you decide how much will each unit of insulin cover, how many grams of carbs, for instance. So for instance, a sandwich is 15 grams of carbs. You actually have to do some math to calculate what the dose would be. Meanwhile, there's another concept too, is how sensitive are they to insulin? Meaning, if I give you 1 unit of insulin, how much will that lower your blood sugars? So this is a dramatic shift in therapy, as you can imagine. It's not just, oh, I take my medications once a day and it's going to work no matter what. It's actually engaging it to the meal and timing and so forth. So there's a lot of education here. And this is where he had worked very closely with our diabetes educator to work on that. Next slide. So first off, by the way, to be able to use this new carb ratio that I calculated for him, he had to first learn how to estimate carbs. So by logging his meals in our app for the first few weeks, Emil was actually able to give him some feedback on his carb estimates and point him towards some helpful resources. So on the top left, for instance, you can actually see the perfect portion scale. This is a really nice tool that lets you basically put your food, weigh it, and then you type in the code that corresponds to the food and it will tell you the amount of carbs, for instance, that is in that meal. It's a really, really helpful tool. Meanwhile, we actually got him on the Smart Pen. So this is the companion in pen, which helps you actually, what's really nice about this is that it actually gives you a lot of the benefits of a pump, meaning it actually gives you a bolus calculator. So it lets him basically reduce the burden of having to do all these calculations manually. Okay. So those were two of the additional kind of things we taught him on top of how to carb count and to doses insulin. Next slide. So with active logging, back and forth messaging, and a couple of video visits to discuss this project, we were able to fine tune his insulin dosing. So on the left here, you start out with the bagel that he found with that weighing on that scale, it was 64 grams of carbs. So we started off with my initial calculations based on his tracking period data, and that I estimated maybe an carb ratio of 15 grams to 1 unit. So if you do the math here, 64 divided by 15, for instance, about five units or so. He gave 5 units, but look at his response. 114 rose to 242. What we really want to see, by the way, is after you give a bolus here, it should kind of bring it back down to where it started, right? So on the right, go ahead, next slide. On the right, you have the same bagel essentially, but we actually, based on his test and experiment type of approach, trial and error, we were able to hone in the fact that he needed more. So we tried it again and again and again. And you can see here then a situation where he had another 64-gram bagel. We gave 6 units, and this is corresponding to a carb ratio of 11 grams per unit compared to 15 grams per unit. And you can see the profile here is exactly what we want. We want your blood sugar to essentially come back to where it was, not to spike too high, for instance. And you can see this type of system really allows you kind of fine-tune doses very quickly. So what did that mean for this patient? If you look at back when we saw him in January, his average GMI, his average glucose at the time was 191. His time in range is 47%, which equates to a GMI of 7.9%. And his most recent data, just from the last couple of days, for instance, you can see his average glucose is holding out in the 143 range, GMI is 6.7%. He's unfortunately starting to have some lows, which is inherent to unfortunately using bolus insulin. So we're going to try to be very mindful of that. But very happy with the gains in time and range. He's almost doubled since in that interval. So good. That's the end of that case. I'm happy to take a pause real quickly, see if there's any questions relevant to that. But then I think certainly let's try to address some of these questions that have come in through messaging or through the FAQ. Okay, well, let me start with some of these questions. I think that maybe we'll just kind of go through them because I think some of these can be answered really quickly, by the way. So have you seen a decrease in medication with the use of CGM? Definitely, as you can see with some of our cases. So just a simple active CGM alone with the knowledge of your glucose patterns and what your lifestyle is doing to it, it can really drive behavior change. I saw there was a couple questions about CT, MRIs. Is the Libre compatible with those? And the general answer for the Libre is no. You should basically take it off for those because it hasn't been studied. They're not sure if it affects the sensor or if it's safe for the patient. Is CGM approved for pediatric patients? Definitely. So I've definitely been using those for patients of all ages. Will insurance cover for type 2 or prediabetes? I think I sort of addressed, but just to answer the question head on is depends on the situation, which is to say that most of the time for pre-diabetes, it may not. So you may have to kind of try and submit for it and potentially use those voucher codes. But that said, I've definitely had some go through. The same happens for type 2. Some insurances are more strict in terms of their criteria, but I've definitely had as well a good handful actually get through and be able to get it, for instance, $30, $40 out of pocket for a full month supply. In terms of the application sites, you're absolutely right that Libre is meant for just the arms, though. The others can be used in other sites. So that is accurate. Finger stick glucose testing is intended. So as Bjorn alluded to, there is a bit of a lag between the CGM and glucose reading. So the main time that's a flaw, by the way, is when your glucose is moving rapidly. So let's say you just had a quick meal. With that lag in place, you might still, on CGM might read, so let's say 100 or 120, but if you check a finger sticker, it could be 160, for instance, if it's rising really fast. So it's meant to be, finger stick in that situation is really helpful to clarify if things are different from that. So for a low, for instance, I would definitely recommend a finger stick for that, because the other thing I haven't touched on actually is a Libre is not that accurate in the low range. 40% of its readings can actually be normal. So for a low, I would definitely recommend a finger stick. And anytime things are kind of a little bit off or expected to be moving quickly, a finger stick is very helpful. Terms of oral GLP agonist is as equally effective as Ozempic. That depends on the data and what you're looking for. Essentially, like there's some areas where it's a little bit better, it's a little bit worse, etc. But it's comparable, I'd say. So in general, I think the Ribelsis, which is the oral equivalent Ozempic, is definitely worth looking to. I have some charts to show you if you're interested. So reach out to me if you like that information. Let's see here. There are special cautions for the sensor getting wet. I think that came up at least once or twice. So you can actually wear this for 14 days. Okay, so actually you put it on for 2 weeks. It stays on your arm. You're able to shower. People swim with this, and otherwise, it's basically not. It can withstand that, certainly. And now, obviously, if you're going to soak in there for an hour, for instance, that might get it loose. So unfortunately, once it does fall off, it's no longer useful. Fortunately, the Abbott actually will replace any sensor that kind of expires before its intended 2-week period. So we tell all our members to really reach out to them if a sensor fails before 14 days. Okay, but you can use it in that case. Do any of your patients ever use a CGM and an insulin pump? Definitely, definitely. CGM, I'd argue, is the most important technology here, because without knowledge of your blood sugars, you can't really appropriately dose your insulin of sorts. But an insulin pump definitely can make a job easier. And as Bjorn alluded to, there's actually much more advanced systems now that can literally take your glucose trajectory and your current value and actually just feed that data into the pump to actually guide insulin adjustments that are made on their own without the patient's active involvement in that case. When do you discontinue use of meter? I think, especially when cost is a concern, I think then you can think about intermittent use. So using it for a short period, trying to answer some very specific questions. I actually will say that when you're on CGM then and your patients are interested, have them test whatever they're curious about. Because if they see it once or twice and know that, for instance, one meal compared to another, the profile is very different, that is powerful, and that's something you can't give otherwise. So I think you can use the CGM certainly in that short term, and then you'll come back to it, for instance, 3 months later or a month later, for instance, and use it to your advantage.
And maybe to clarify, if the intention was to ask about a blood glucose meter, all patients need to have access to a blood glucose meter as well as a backup and to verify readings in certain situations.
Correct. Do you recommend CGM for patients that are not compliant with managing their diabetes? I'm a student. So yes, I've definitely had actually many patients where, like, for instance, I had one that came to me with retinopathy, A1C is above the detectable range, 16%. He just had no idea whatsoever. And actually just knowing his values and being able to actively make changes in the course of just 2 weeks really changed his compliance, we'll say, and his motivation to really improve. He dramatically improved his A1Cs just in that short time frame, and he continues to wear it because it's been so powerful.
Yeah, and if I may add something, I think being able to have that data to base any discussion on, rather than basing it on a few values and clinical experience, really puts the decision in the patient's hands. And I think we've seen several cases of how valuable that is to the relationship between patients and provider.
There was a question about, would you recommend a Libre for a type 2 elderly patient with uncontrolled blood sugars in the 200s regularly who is not able to accurately reduce carb ratios? Yes, because I think in those situations, a lot of times they may be having certain meals frequently, right? So you may be able to, using the Libre, kind of help them, first understand what the profile is for each of those meals. And then from there, tailor your treatment accordingly. Let's say they're on insulin, for instance. You can actually, over time, figure out what the right dose is so that you can, what I like to do essentially is give them a menu, right? When you have this, piece of cornbread, you give 2 units, for instance. And they can kind of, that gives them a lot more understanding and flexibility with their meal planning and overall. There's a question about a 7-year-old on a CGM Dexcom with the pump that loops and is supposed to adjust the highs and lows. How do you deal with a parent that is obsessed with CGM results and wants to sugar surf, adjust for highs and lows all the time? That's a challenging question. Obviously, in pediatrics, there's this kind of a divide where they're not quite able to make their own decisions per se, and the parent obviously has a role in their care. It's a tricky transition, obviously, because obviously when they get to 18, for instance, it's not like something magically happens, right? They have to take more responsibility for their care too. 7, I would argue, is on the younger side, so there is going to have to be some give or take there. But I think it's first making sure. I think it's important to put things in perspective, though, in that situation, which is to say the highs and lows, those short-term fluctuations, aren't what matter, right? What matters is quality of life and that you maintain reasonable glucose control. For that, for loop in particular, it's about getting the settings right so that you can optimally control blood sugars the best you can. So making sure that they understand that and not fret about every single value, I think is key. And that's where, for instance, talking to a mental health professional may be really helpful to understand that better. There was a question about how do you remove the CGM? Can patients remove the CGM? Are they reusable? They are not reusable. Once they fall up, unfortunately, they can't be used anymore. Removing is very simple, actually. You literally just rip it off, actually. So what I usually do I'll take a little, maybe something wet or otherwise, sneak it under the adhesive and just kind of gradually peel it off. But essentially, all you're doing is just peeling it off. And finally, there's a question about, are there any contraindications? I would argue no, not really, because it's non-invasive. It's very simple to put on. It gives you far more data than a finger stick, for instance. And the funny thing, actually, with insurances, a lot of times they argue that CGM is too expensive. But if you think about it, sometimes with finger stick, like the test strips, I should say, being costly and checking, let's say, 10 times, 12 times a day, they're actually comparable in some cases, actually. So I don't think there are any contraindications personally. There was a question about, I have never used the Libre, but do you have to set the target range for a patient, or is it set automatically to 70 to 180? Very, very good question. Unfortunately, when you download the app to the Libre, it defaults to something else. And I've had many patients misinterpret their own time and range and think that they're doing far worse than they actually are. So I think that raises a great point that you should, for someone who has type 1 diabetes, type 2 diabetes, setting that range for them, being clear about 70 to 180 is very helpful. Occasionally, you have a patient that actually warrants like a more tighter range. So for instance, pre-diabetes, I often use 70 to 140 because that's a little bit more realistic for the situation. But that said, you should specify that to the patient. Have there been reactions to the adhesive used with CGM is another question here. There have. Unfortunately, some people just seem to have reactions more than others, and it's sometimes very specific to the device. Like some people, for instance, the Omnipod adhesive is just very problematic, but the others aren't. So unfortunately, your mileage will vary, we'll say.
Thank you, Kevin. I think you've gotten through almost all the questions, which is impressive. We are approaching the end time in about 20 seconds. But so we'll skip. We cannot answer any more questions right now. If you do have more questions, if you want to get in touch with us, you can go on the website steady.health. I'll also send out an email to all the participants so that you get our contact info, and we're happy to get on a call with you to discuss the technology or an individual case. So please follow up and keep in touch with us if you have any more questions. We will be sending the slides to the California Association of Nurse Practitioners. They will be following up with a survey, and I'm sure we can either put it as a download in our follow-up, or the Association for Nurse Practitioners can provide it for you. I want to wrap it up by really thanking all of you for taking time out of your day. We hope that, despite some technical challenges, we've been able to provide you with something exciting, something new, and something inspiring, most of all. And I hope that this will, enable you to bring some new content to your practice. And with that, I want to thank you. I want to thank Calvin for doing this with me, and thank you all for coming today.